Good morning, everyone. My name is Maya Luria with TMC for Seniors, and I am super excited that we are having a Survivorship Series. I have Dr. Shana Semmens here with me today. If you have not heard Dr. Semmens talk before, you're going to love her. She is our medical director for our palliative care program, and today she's going to be talking about Comfort First, rewriting the pain narrative in cancer care. How are you, Dr. Semmens?
I'm very well, Maya. How are you?
Good, thank you. So you do have an online audience that's watching today, along with an in-person audience. And I apologize, we did start a few minutes late. We have a lot of new people here today, and we're really excited about that. So I've gone ahead and put your PowerPoint up. If you have a question for Dr. Semmens, please feel free to leave those in the chat, and I will ask her afterwards. I'll turn it over to you.
Thanks so much. And thanks all of you for joining this morning. It's really exciting to see such a big group, and hopefully I answer some questions and we get to some of the information that you're hoping to receive. So like Maya said, we're going to be talking about pain in cancer care and cancer survivorship. First of all, I'm going to start with what palliative care is. I think that's the first thing I talk about in any of my consults because it can be a nebulous idea or it's often confused with other things. We're going to talk about the different types of pain and how those are addressed with the palliative medicine team, different treatment options for those different types of pain. And we're also going to explore a little bit the different themes of healing, curing, and suffering and how that works into pain and people's perceptions of the different types of pains that they might be experiencing throughout their cancer journey. So what is palliative care? It is a medical subspecialty that supports people living with serious illness. And I think we can all agree that cancer is a serious illness. We do a lot of cancer care. Our palliative care team and our palliative care clinic also supports patients with other serious illness such as heart failure, advanced COPD, maybe liver disease or kidney disease, maybe even dementia. So we see a lot of those things, and often those different disease processes can overlap with something like cancer. So we take it all into context. We really focus on quality of life throughout treatment and after treatment of different disease processes, and we want to prevent and relieve any suffering. It is often in addition to other disease-directed treatments, so like chemotherapy or radiation, and then after those types of treatments, we can still support because sometimes there's still pain after those treatments, or sometimes there's pain after surgeries for different things. We really aim to look at the whole person. So not just the physical being, not just the body, but also their psychosocial and spiritual needs as well. And we use a team-based approach, which I'll talk about a little bit more in just a second. What are the benefits of palliative care? Well, like any good medical subspecialty, we have a fair amount of literature to back up to see if what we do actually matters or works or helps people. Not only does it increase patient comfort, it also increases patient and family comprehension about what's going on medically because it can be really complicated and really overwhelming. And when you're feeling like you're in a crisis mode, maybe hearing that word cancer, you automatically don't process as well. You're automatically a little less smart than you really are because your brain is too overwhelmed to hear everything. And so we're another layer of support to kind of talk about what the treatment options are, what the disease means. And we can repeat that as often as is necessary until people feel like they understand what that means. We also increase family satisfaction with care. It decreases family and patient anxiety, depression, and post-traumatic stress disorder. Decreases conflict in general, whether that's conflict between doctors, conflict between family members. We really aim to make sure that everybody's on the same page and know what the plan is moving forward. And then if you happen to be hospitalized during your treatment for whatever serious illness, it also decreases how long you're in the hospital, which in general, most people are pretty excited about because the hospital isn't the most fun place to be. We have hospital and clinic-based teams here at TMC, and we help our patients in a lot of different ways. We kind of individualize it to what the patient needs, but the two main things that we do is we try to get to know you as a human being and understand what's most important to you so that your medical care matches up with those goals and values and what you want. We also help with symptom management, whether that's pain, nausea, shortness of breath, constipation, anything physically that's kind of lowering your quality of life. We aim to reduce those symptoms so that your quality of life is better. You can tolerate treatments better. You can live your life more fully. We also work very closely with other hospital-based resources, including our spiritual care team. We work closely with volunteer services, with things like pet therapy, to really try to make sure that if you're in the hospital, it's as pleasant an experience as possible. And in the clinic, we try to make sure that we are coordinating with all your other specialty providers, your oncologist, your cardiologist, whoever that may be, so we're all on the same page with what's happening and moving forward. So who's in our team? We have 4 fellowship-trained, board-certified physicians, and 3 of us do clinic on Wednesdays at the TMC 1 Beverly Clinic, which is just kind of across Grant Street from the hospital. We have 2 nurse practitioners, a nurse coordinator, and a social worker. So when I say it's a team-based approach, it's really true. Sometimes the best person for you may not be me as a physician. It might be our social worker. Or sometimes personality-wise, you get along better with a different physician. So we really work to make sure that you're getting the optimal experience possible from your care team. So what is pain? That's a big giant question, isn't it? Not only is there physical pain, but we in palliative care often explore emotional pain, social pain, spiritual pain, and existential pain. And we're going to go through all of these different types of pains and kind of how we address it as a palliative care team. One thing that's really important in cancer care and other disease processes is whether or not the intent of treatment is curative or to just prolong life and improve quality of life. And we talk a lot in palliative care about even if cure isn't possible, healing can be. And feeling like you're yourself instead of a cancer patient, which is something that one of my clinic patients told me a couple of weeks ago. For the first time in years, I feel like me instead of just a patient with cancer. That's huge, right? We want to make sure that you feel like you, not your disease process. A lot of times too, there's a difference between suffering and pain. Sometimes something is painful, but it doesn't necessarily mean you're suffering because of it. Or I sometimes have families say, well, they're not suffering because they're not in pain. But that may not always be true, because maybe they're questioning their role in their family, or maybe they're questioning why this is happening to them and they're having an existential crisis. That still very much is suffering, and we want to address that, even if, let's say, like their back doesn't hurt or their knees don't hurt. And so we often kind of talk about all of these different things of what is a pain that we can be treated with different things, or what is suffering and how can we still address that pain, even though it may not be a physical pain, to make sure that people are feeling as well as possible. Does that make sense? Okay, good. So physical pain. Why does physical pain happen? We have tissue damage. So especially in cancer care, the tumor is invading other areas or replacing different things or growing in areas and making things stretch, and that hurts. We also have inflammation because of that, and so that's a different type of pain than the direct tissue damage. And then there can be nerve involvement. So there's lots of different physical types of pain that we will ask you a lot of questions about to try to elucidate what's the best treatment for those different types of pain. Because the best pain medicine for tissue damage may not be the best for nerve involvement. How do we address these physical components of pain? Well, a lot of times we do talk about medications. Sometimes it's anti-inflammatories, whether that's something like an NSAID that we can commonly do over the counter, like ibuprofen or Advil. Sometimes that's steroids. We do often use opioids in cancer treatment for pain. Those are things like morphine, oxycodone, those different things. And again, we only use what is necessary for a patient to feel better and more functional. We also talk about nerve medicines or other kind of adjuvant therapies, other things that kind of help address pain in different ways. And I didn't want to bore you. I didn't go to medical school to learn all the pharmacotherapy, but there are lots of different things that we look at. It's not a one-size-fits-all approach. We also coordinate with things like physical therapy. Maybe your pain doesn't need a medicine at all, but it needs to work on posture or balance or how to move differently so that pain isn't as much of a limiting factor in your life. We also work with our pain interventionalists who do nerve blocks sometimes. I've been able to get my patients nerve blocks and they completely come off of pill pain medication. Well, that's a quality of life improvement, right? Not only are you not taking something every day or multiple times a day, but you're not getting any side effects from those medicines too. And then we also talk about integrative therapies. What integrative therapies, you may ask? The list is extensive, and the data sometimes is there or sometimes maybe isn't there, but there's very little harm in it, and different people get benefits from different things. So we talk about acupuncture. There's not great, robust evidence in the literature that it helps, but anecdotally, some people absolutely get huge benefit from it, and it's pretty low risk. Breath work, so just breathing and understanding how to support your body through different physical sensations. Guided imagery, that has a lot to do with closing down your mind, going a million miles a minute, focusing, redirecting energy. That can be really, really helpful. Hypnotherapy, hypnosis is really powerful. Sometimes the struggle is finding a practitioner who can do it. Sometimes with these integrative therapies, the struggle is insurance coverage, but we really work with people and try to figure out ways to do this. And technology can be really helpful. There might be an app for that. Massage has mixed literature to support it. Some studies show that it's really helpful. Some studies show that it's not necessarily helpful for pain, but in general, people really like it. So we can help you find different ways. Different cancer centers have relationships where massage therapists come into the cancer center, and there's also community resources where they know if you have a cancer diagnosis, you can get a discounted rate. Reiki, limited evidence, but can be really, really powerful, and it's often available in a lot of different, even hospitals. Reiki is kind of energy healing and moving energy. Music therapy does have robust benefits in the literature, and reflexology also has some benefits. So depending upon who you are as a person and how interested you are in these integrative therapies, we talk about these in conjunction with a kind of more Western medicine medication approaches. We also address emotional pain, and I think this is a huge one in cancer care. There's a lot of anxiety, depression, adjustment to this new way of being, this new thing that you're worried about, and there's often anticipatory grief. So anxiety, especially in survivorship, is it going to come back? Am I going to constantly live the rest of my life fearing that this cancer diagnosis is going to be there again? Or my family treats me differently. Like the cancer is gone, but like everybody's still worried and trying to like not let me do the things that they used to let me do. How do we talk through all of those things? Anticipatory grief too can be really important, and without addressing it, it doesn't get better. And so that's the grief of I have lost something or I'm going to lose something and I'm already kind of upset about it. And that's okay. That's normal. If we don't talk about it, it doesn't get better. And if we do talk about it, it can be really helpful and freeing just to kind of get it out there. I have a patient who comes to my clinic and she has a cancer diagnosis. She's doing really well right now. She still comes to me every once in a while with a what if question. And we talk about it. We make a plan for the what if, and then she feels better. I sometimes worry as a physician that I'm not actually helping her that much, but she keeps coming back, so clearly I'm doing something. And I think one of the things is I take her question seriously. I'm not saying that that's not going to happen or we're not there yet, so we don't have to worry about it. We're addressing it. We're making a plan for it. So how do we address emotional pain? Sometimes just talking to me is enough. Sometimes I am not enough, and we talk about finding a therapist. We talk about finding a support group. I don't have cancer. I do not know what it's like to have cancer the way that another person who has cancer knows. And so we can talk about the different support groups available for that. And then again, integrative therapies as well. So sometimes acupuncture is awesome for anxiety. Sometimes Reiki, people are like, oh my gosh, I almost fell asleep. It was so relaxing. I love it. Great, let's do it. Social pain. This one's a big one. All of a sudden, life got topsy-turvy. I just met a patient a couple days ago who was working through her initial cancer diagnosis. Thought things were clear. Things are not so clear anymore. And now she's not working, and that is a huge problem for her because she felt pretty normal and she felt distracted by going to her job. She loves her job, and she's not currently able to work. So one of her goals is controlling things well enough with the new treatment plan to go back to work. That's her goal, so that's my goal. We have a whole bunch of things to try. I'm going to see her again pretty soon. We're going to see if we can get her working. Her goal is mid-October, go back to work. So that's what we're trying for. But that's been a huge shift for her of like her identity and her role in the family. Oftentimes too, there's a lot of financial stressors about things, about working not being an option anymore. And We always like to think that finances have no implication on what kind of medical treatment people have, but I also feel like that's just a big giant lie, right? Because having to like go to work or not go to work or having to pay for really expensive medications or not are huge deals, especially for people that might be on limited or fixed incomes. So that's something that we talk about. I'm always like, this is the cheapest medicine. Let's start here. And if we need to change it, we can. I don't want you spending your money on medicines, but you can spend it on trips or flowers or, I don't know, zoo memberships. Like let's have fun instead. Family dynamics often shift. So maybe the head of the household isn't necessarily feeling as head of the household. Or maybe the person who's always been the caregiver, caretaker, the giver, needs to accept some of that love from their family members. But man, is it hard when you're used to doing things for everyone else to let people do things for you. It can also affect friendships. Sometimes the friendships change, sometimes the friendships go away, and all of that can be really difficult, and we talk through all of those things. A lot of times people worry about being a burden. It's a very common concern I hear, and I often hear the family say, you're definitely not a burden. No, it doesn't matter, they still feel that way, and so we talk about their perceptions and how we can help with that. Sometimes the social pain can be addressed by, again, just talking about it and adjusting to the new roles. Sometimes we can also do things like advanced care planning documents to kind of plan for the future so that the family is aware of the wishes of the patient so that if different things come up, we know what to do. We are not lawyers, so I can't really tell you much about estate planning or wills or custody things, but we can set you up with lawyers. And we can talk about maybe this is bigger than what we know. And I have had a lot of success with different lawyers, even doing pro bono things for patients in different situations. And so depending upon the needs, we find the resources that need to help. Spiritual faith. A lot of times something happens and it makes people question their faith. Why is God doing this to me? What did I do that is making me be punished now? What will God say or think if I do this or I don't do this medical intervention? I'm going to tell you right now, I'm not a spiritual care expert, but I know chaplains who are, and I hook you up with them to actually address those questions a little bit more. And I know that even in Southern Arizona, there are regional differences in how people interpret theology, and I am not the expert to say how that works for you, but the chaplains can help you walk through that thinking. And so we often coordinate with our chaplains. Our spiritual care department here in TMC is awesome. And so we make sure to address that and ask about your faith and how that helps inform your decisions and your support network. But we also don't pretend to know more than we do. But we have resources, we have friends. And then existential pain. This one I have often had patients try to treat with medications, and it doesn't work because the medications are for the physical pain, not the existential pain. And sometimes it's really tricky because you can have physical pain and these other pains. And so we have to tease out which one is kind of the bigger player at different times within your treatment process. Sometimes people question their life's purpose. What is this illness trying to teach me? What is this illness's purpose within my family? Why is this happening to me? A population that has been really interesting to learn more about is the veteran population, especially with Vietnam. There's a lot of people who kind of think that their disease processes are a karmic return, and maybe they should be suffering because of the things that they had to do or had to witness with their military service. And that is not something you're ever going to get out of someone unless you directly ask about that. And so we often ask for permission to go deep and ask hard questions. And if someone says no, that's fine. They're the boss. But if someone invites us in, we are not afraid of talking about these really hard things and finding the resources to help make sure that we're addressing them. Because, I remember meeting this really grumpy veteran who was like, I don't need you. I was like, okay, can I just ask a couple questions? Yeah. And then by the end of our hour-long visit, he was like, I'm really glad you stayed. I feel a lot better just having talked to you and having a plan for how we're going to address all the different types of pain he was feeling, physical, emotional, existential, all of those things. So this is an overview of how palliative care thinks about pain. The other thing with cancer survivorship that's really important is that even if the cancer is gone, sometimes the path to get the cancer gone was not so easy. So maybe there's post-mastectomy pain, there's scar pain, there's nerve pain from whatever surgical procedure happened. We continue to see our patients even after their cancer care may be finished because they're still dealing with those sequelae and need additional support and help for however long it takes for them to feel better, feel functional, and kind of move on from there. So sometimes if we do think that there is curative intent or we're working towards remission, whatever that may be, we have really honest discussions about this is what we need to get through treatment. Once we're through treatment, here's the plan about how we're going to maybe back off of these medications or why we're going to keep these medications to continue your functional status. This painting was a gift from one of my patients who had that scenario. She had a bone kind of muscle cancer in her leg that was really, really painful. There was the possibility of cure. But when I met her, she said, I can't do anything. I'm an artist. I can't even look at my paintbrushes. Like, I cannot do anything other than think about my pain. We addressed her pain. Her cancer team addressed the cancer. And then after the cancer was gone, we weaned off of the pain medications. And on our last clinic appointment, because she was going to graduate from palliative care, she brought this amazing painting for me as a thank you because she was able to do what she did again. And I think one of the most special things about this painting is that it's of a place in Scotland. Anybody been to Scotland? Okay, I'm going to ask you later because I really want to go. It's called Rest and Be Thankful. And this is a vista in Scotland where a lot of people go. There's a bench on the mountain, and it's just beautiful. And so I think of this a lot. It's hanging in my office right now. This is literally a picture on my wall. Because what an honor it is to meet people in very scary times in their lives and help them walk that journey. And this is just such a reminder of how that beauty can still be there. There's a lot of pain. She wasn't who she felt like she was beforehand, but we got her back there. Things were a little bit different, right? She had gone through a cancer journey. She was a different person, and she grew through that. But we were able to get her to that survivorship place where she was herself again. And she didn't need me anymore, which was awesome. I always tell my patients, I hope I don't see you in the hospital anymore. Let's like run into each other at the grocery store. Okay, any questions? Yes, sir.
Oh, real quick, we'll do the ones from online first.
Online first.
Yep, sorry. So thank you. I do have a couple of questions that came in. So one is, can you share with us a little bit about the outpatient clinic?
Sure. So our outpatient clinic is at the TMC 1 Beverly Clinic, which is across the street from the TMC kind of Grant Hospital. We are there on Wednesdays. There's 3 physicians who work there, so we have morning and afternoon appointments. To get an appointment there, you should ask any of your physicians for a referral to palliative care, TMC 1 Palliative Care. That will go to Jeanette, our nurse coordinator. She'll get the medical records and make sure that we can address what needs to be addressed. We do not treat chronic back pain. That's not our specialty. But if people have chronic pain and they get cancer on top of that, we are able to help them get through that cancer diagnosis. The other thing that we're not currently able to support right now, and it's because of just resources, and we're working on it, but not currently, anybody with an active opioid use disorder, so using opioids that are not prescribed to them or incorrectly, different ways that are prescribed for them, we are unable to fully support them because that takes additional multidisciplinary team members that we don't currently have. But yes, we see all comers in the clinic, and so just get a referral and we'll get you scheduled. Right now, we're booking out 4 to 6 weeks for new patients. If there is an urgent need, like out of control pain and I can't live my life, we do what we can. I added on a person yesterday. So we try to get people in as quickly as possible, especially with cancer care and especially with functional issues and severe symptom needs.
And when you, and what does that first appointment look like? So because that one is in person, right? And then could it be virtual after that, or how does that work?
So we are selfish little doctors, and we like to see you in person so we can touch you for our first encounter. We do physical exams. We need to understand exactly what's going on. So yes, it's an hour appointment slot. If you have any advanced care documents, bring them with you because we'll ask about those. What we do is we get to know you. Who are you? Who's your family? Where are you from? What do you like to do? What are you not able to do that you want to be able to do? How is your treatment plan looking? How do you feel about this treatment plan? All of those different things. And then we go kind of step by step through the different symptoms that are bothering a patient. So yesterday we talked about pain, we talked about constipation, we talked about nausea, we talked about fatigue, we talked about dental pain, and we talked about anxiety. And so we went through all of those things. We have a plan for all of them, and then we create a follow-up plan. That follow-up plan depends upon the patient and where they live. We service all of Southern Arizona. So sometimes my patients live in Benson or Safford or Green Valley or Nogales. And so those are very difficult to travel up to Tucson all the time, especially if you're undergoing cancer care and you've got 9 million oncologic lab draws, infusions, et cetera, et cetera. So we do our best to do telehealth, which is either on like your computer or your smartphone. And then depending upon what medications we're doing, there is some frequency of in-person check-ins that is needed. And that some of those are state rules that if we're prescribing you opioids for a long period of time, there needs to be face-to-face documentation per insurance guidelines and things like that.
So we would go there instead of the primary care doctor?
So oftentimes we're not a replacement for primary care. The question was, do we go to you instead of primary care? Oftentimes we work with primary care because we're a medical specialist, just like a cardiologist who doesn't necessarily do your thyroid medications, right? And so we coordinate with primary care and we can figure out who's doing what in terms of medication management.
So the primary care would still be?
Still have a PCP. Former PCP, the PCPs are amazing. PCP can get you the referral, your oncologist can get you the referral or whoever else. And then we coordinate with them. So we're constantly sending notes or calling them to say, hey, this is what we've learned. This is what we're changing.
And I know you said that it's about 4 to 6 weeks right now to get into the outpatient clinic. How long do you normally see somebody for? How long is that period?
Great question. Totally depends. I have had patients where I see them once, and honestly, they're maybe closer to end of life than we realize, and then we walk through things, and then they're transitioning to hospice care, and I don't see them again. I have patients that I've been seeing for years. It depends upon what the patient needs and what the patient wants. If the patient wants to see me, again, I have that patient where I'm like, I don't know that I'm actually doing anything for you, but she keeps coming back, so I'm doing something. She continues to want to see me. So that's very individualized for the patient. Okay. Sometimes it's through their cancer treatment. So the lovely woman who painted me that painting, I think I saw her for a year and a half, and then she was through her cancer care and on the rest of her life.
Another question that came in is, who is the lead in an end of life situation? So what do you do at that point? If you're looking at maybe, I guess, transitioning to hospice then, is that correct?
Yes, so end of life care specialists are really the hospice team, and that is an insurance benefit that affords you a package of a medical director overseeing medications, nursing visits to the home, technician help with bathing, medical equipment, social work chaplaincy support for anybody whose diagnosis would not surprise the physician that they would be dead within 6 months. Now, many people live on hospice for longer than 6 months, like Jimmy Carter was on it for over a year. He's a great example recently. Some people are on hospice for a much shorter time, and I think that's because culturally in the United States, we like to pretend that death will never come for us and that we can always avoid it, and we can't. So statistically speaking, hospice is a 6-month insurance benefit, but the average amount of time a patient is on hospice is about 2 weeks in this country. So there's a gap there of what they maybe could have had. So yes, hospice is generally end of life specific, and we talk about that transition. And I have had patients and we become close and they don't want to lose me as a part of their medical team. And so I become part of the hospice team as like the secondary physician. So the hospice medical director is the one doing the day-to-day things, but I'm still involved. I'm still kept up to date. Telephones still work. I always say, like, even if you discharge from my practice, it's not like the phone stops working. If you have a question, call me. We'll figure it
Okay.
out.
What sort of advanced care documents should somebody have? And I know you oftentimes discuss those during your appointments. So you touched on that, but like, what are the documents just in general?
Oh my God, you guys are like the best. Here is one of my favorites. This is the Arizona Prepare for Your Care. So this is a double document that has a medical power of attorney portion as well as a living will. And medical power of attorney is the person you designate and you sign with a witness or a notary that if you are unable to communicate to your medical team, that's the person who makes your medical decisions. Medicines, treatments, surgeries, hospitals, skilled nursing facilities, hospices, all of those things would be their decision if and only if you are unable to communicate to the team. Maybe you're so ill in the hospital that you're confused, or you're so ill in the hospital that you're intubated and on the breathing machine in the ICU and we can't talk to you. This is the person who would make those decisions. I think that document is the most important document. Who does the doctor call if you can't talk for yourself? There is a legal list of people that we would go to if you don't have a medical power of attorney. So it's spouse, adult parent, adult children, all the way down to friend. So there's backup mechanisms, but as I like to say, sorry, Maya, you got to hear this again. Sometimes the most obvious person isn't the best person to be your medical power of attorney. And my sweet dear husband knows that I throw him under the bus. He's not my medical power of attorney. I like him. He likes me. He knows what I would want or not want. But I'm a doctor and he's not a doctor. And if I was sick enough to not be able to tell the doctors what I wanted, he would be an emotional disaster, crying in the corner. He would not be in a good place to make those decisions. So as a doctor, I'm very fortunate. I have a lot of doctor friends. So my good friend is my medical power of attorney because she would include my husband in the decisions, but she would be able to keep a level head. So this document too talks through who is the best person, because maybe the husband isn't the best. Maybe the best friend is, or maybe the niece is, because you're really close with your niece. And so that's the most important document. The back of this, and 5 wishes is another kind of way to get at this, is the living will. The living will is very different from what we normally think of as wills, where it's talking about your house and your car and your china, where's that going? I love china. I don't care where your china goes. What I care about is what you want medically. So are you okay with resuscitation and things like CPR and life support in the ICU? Or that's not your cup of tea anymore? Are you okay with ever being on dialysis? Are you okay with being in a nursing home? These documents get at those types of things. The reason I like the Prepare for Your Care so much is that it really talks about a spectrum of quality of life and quantity of life and tries to get at what are the deal breakers. If I'm not able to do X, I'm not interested. That is not an acceptable quality of life for me. 5 wishes is really awesome if you're the detail-oriented person who is totally fine talking about your funeral. Because what this document does, it goes into funeral planning too, much more than this document. And for some people, that's scary. I've given this document out because I had it. And people are like, are you trying to tell me I'm dying? I'm like, no, you're not dying right now. And they're like, but you gave me this document. You're really not dying, but this document has scared people before because it's much more detail-oriented for end of life than this one, which is really are you okay being in a nursing home? Do you want to live as long as possible no matter what? Or are you only willing to live if you're able to walk the golf course? And I say that example because I had a patient say, if I'm not able to walk the golf course, that's my line. And I was like, really? Okay, good to know. There's also the Attorney General form. This one, in my humble opinion, is a bit legalese and a bit narrow. So these other 2 really talk about what you're able to do in your function and what's important to you. This one's if I'm in a persistent vegetative state, which is a very narrow diagnosis that we don't often see, yes or no. And so this one is just a little bit narrow, and it's not as easily used by other physicians in the hospital. Whereas the prepare for your care, I've literally had an ICU doctor come up to me and be like, oh, you guys filled this out with this patient. And then I was able to say, like, this was possible or not possible. We made decisions based upon it. And I didn't even need to call the palliative care team. I was like, yes, that document works then. We like that one. And then the other one that could be important to you is what we call the orange form. This is an Arizona specific, and I say that because I know sometimes we have people who are really lucky and live part-time here and part-time other places that aren't 1.5 million degrees in the summer. This is Arizona specific, which is an out of hospital, so at home, do not resuscitate form. So this is for people who do not want resuscitative efforts, they don't want chest compressions, they don't want to be on life support. And for people who have made that decision and want to make sure that if something happens and EMS comes to your home and they don't accidentally do that to you, this is important to have. Arizona, home state, so I'm not trying to dig on them too much, is pretty far behind nationally on another document called the POLST or the MOLST, which is a physician order for life-sustaining treatment or a medical order for life-sustaining treatment. That nationally is kind of like an orange form, but it's a little bit broader and not just about CPR and resuscitation, but you can also say whether or not you would want surgeries or dialysis or things like that, artificial nutrition and hydration. That is another form that we talk about, especially if you are traveling and not always in Arizona. Like I've had patients who are like, oh, I go back to Minnesota every summer. I'm like, well, the orange form, they don't know what that is there. So let's have the orange form for Arizona and the POLST for Minnesota.
Pulse, P-U-L-S-T.
P-O-L-S-T.
Thank you. Now, I did have another question that came in. How is the cost of palliative care covered? Like, for instance, is it covered by your insurance?
It is. So however that insurance works, which I am no expert in, it works. I have not ever had a patient say to me that they had like a crazy copay or that the insurance coverage was such that they were not going to continue using our care. I'm still working out how we can do uninsured care. So that one's unfortunately not figured out quite yet. But if you have insurance, you're good to go.
Okay. And one last question is how do you manage balancing pain and still being able to not feel drowsy or have other side effects from the treatments, from your pain medication treatments?
Great question. And we talk a lot about the different ways to treat pain that are not just a bunch of medications and using the lowest possible dose to minimize those side effects. Sometimes if one medicine isn't working, just switching to another medicine in that same class is really helpful. Sometimes there's different delivery methods. So sometimes maybe taking it by mouth isn't helpful, but maybe taking it as a suppository decreases some of that. Sometimes we use a little bit of one medication and a little bit of another medication so that they work together against the pain, but decrease things like drowsiness. The one, if you're on an opioid medication regularly, the one side effect that never goes away, no matter what we do, is constipation. And so we just really aggressively manage a bowel regimen to make sure that we're preventing that. And we give all of our patients like a little like what to do if I'm feeling constipated, like a flow sheet of what to do at home so that you don't get too far behind. But yeah, we think about other options. I had one patient, she was really drowsy from her medicines, and so we got her a nerve block. That was great. Sometimes we talk about long-acting versus short-acting because the long-acting medications tend to have less of those kind of acute side effects because it's a sustained release medication, so you're not kind of getting the huge effects all at once.
And so you're really working with their whole care team too, correct? I mean, you're working with their oncologist or their primary care. So you become part of that, sort of that whole care, the spectrum of that care team.
Absolutely. And, we work with your oncologist and sometimes we're saying, hey, do we need to get a radiation oncologist, a radiation doctor on board? Maybe radiation would help with this pain, which again, has maybe the side effect of fatigue while you're going through the treatment, but then you might be able to reduce the amount of medicines that you're taking for those things. So we're talking with your oncologist, we're talking with your primary care doctor, whoever are the key players in your care, we're discussing with them.
Great. So, Dr. Semmens, I'm going to wrap up with our online audience. I do want to share the phone number for the outpatient clinic. One last question just came in. Are you available in my chart?
Yes.
Okay, so I figured that was a yes.
I will say though that my chart, just as everybody says, is not for like emergency questions. And the my chart messages don't always go directly to me. They go to like a medical assistant and then gets routed to me. So please give your doctors grace with my chart, because as soon as I get it, I respond to it. But I've had it where like I didn't get the message until Wednesday, but it actually came in on Monday, but it took that long to get to me. And then Maya, we do have some questions here. So
okay, yeah. So I'm going to wrap up with our online audience, but I do want to share the phone number, and then I'll turn it over to you for any in person. The phone number is 520-324-3771. That is for the outpatient palliative care clinic. You do need a referral to utilize that. But they can help you and help you navigate that process and let you know more if you are interested. Thank you so much for being here today. I am going to turn it over to you for any in person, and I appreciate you being here. Thanks.
Thanks.
Thanks again for joining us today. We are going to be back next week with more on our survivorship series. We have the role of diet and nutrition in prevention, treatment, and survival. That is going to be Tuesday, September 16th at 1 p.m. If you're interested in this class, please give us a call at the office. The phone number is 520-324-1960. Thanks so much and have a great day.